Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. I am Dr. Faisal Faiyaz Zuberi, working as Assistant Professor of Pulmonology and in charge of the chest unit 2 at OJA Institute of Chest Diseases, D.U.H.S of Health Sciences, Karachi, Pakistan. Today we will discuss a very interesting and very important topic, which is known as asthma. How to diagnose asthma, what is asthma, and how to manage asthma. So these things we will discuss in the next few minutes. Let's start. So we start with the first thing, diagnosis. So definition. So definition seems to be very much, required a lot of sentences, but it just shows how difficult it is to even define asthma. But I can tell you it's easy to diagnose asthma. So classically it's defined as a heterogeneous disease characterized by, number one, chronic airway inflammation, and characterized by wheezing, shortness of breath, chest tightness, cough that vary over time and in intensity, together with variable expiratory airflow limitation. So their classification. Number one need to understand that asthma is a heterogeneous, not a homogeneous disease. It's got heterogeneous components, different types, different phenotypes, different presentations, different aspects, and characterized by airway inflammation. So it's not an infective disorder, it is an inflammatory disorder of chronic origin. This has to be clear in mind. Then the definition of the symptoms, very important: wheezes, shortness of breath, chest tightness, and cough. They are the very common symptoms. But the major thing is that they vary over time and as well as in intensity. The spirometry, which is what written here, variable expiratory airflow limitation. Here, this thing, this line. So what does that sentence mean? As you can see, it's an expiratory. The spirometry, we are talking about the expiratory maneuver. We do it by expiratory maneuver. Airflow limitation by definition is when the ratio of FeV1 over FVC is less than 70%, is known as airflow limitation. So another part of the definition is variable, means when we do the baseline spirometry, also known as, the airflow limitation if present, that means the ratio is less than 70, for example maybe 50, which is obviously less than 70, and after the bronchodilator, the post bronchodilator study, the ratio becomes 80, for example. So that means what? That the post bronchodilator study, the airflow limitation has gone, has been abolished because it has crossed the 70. So this means this airflow limitation, which was present initially on pre-bronchodilator value, is not present on the post bronchodilator value, which will make it a variable thing. So this is the way it is going. Whereas in COPD, it is generally characterized by the persistent airflow limitation on the post bronchodilator study. And another term arises having person features some of the asthma, some of the COPD, and it is the overlap. We call it ECHO, asthma COPD overlap. Now we go by stepwise approach how to diagnose asthma, and for this, for an adult who present with respiratory symptoms, what the question is, does the patient have chronic airway disease? If the answer is yes, then what is the syndrome? It belongs to asthma, COPD, or the overlap. Because chronic obstructive disease can have all these three. Or entry, and how to initiate the initial therapy, and when to refer these patients for specialized centers. So step one, the first question, Do the symptoms suggest chronic air disease? If the answer is yes, what are those symptoms? The symptoms are chronic or recurrent cough, sputum, dyspnea, or wheezing, or repeated acute lower respiratory tract infections. If the patient has previously been diagnosed as having asthma or COPD, or previously patient has a history of, when you ask the patient, they say, yes, I have been using an inhaler for the past 2 months now. So this gives an idea related to obstructive airway disease, or any history of smoking, tobacco or other substances, or there is an environmental hazards present. So all these points in the history one has to ask. This will try to build up the diagnosis of asthma. Examination may be completely normal in a patient with asthma, but if you are lucky enough, you would be hearing the wheezing, which are polyphonic, bilateral, widespread, and are not localized to one area. Because if you hear a wheeze in one area of the lung, localized wheeze, then you need to rule out the endobronchial, maybe a foreign body, especially in children. But in adults, it can be a lesion, maybe a mass, maybe an endobronchial malignancy. But having said that, the important thing is the wheeze of asthma is polyphonic, not monophonic, and it is present bilaterally, widespread, and expiratory. Other evidence of hyperinflation may be present, which can be shown by the tracheal tug, the barrel-shaped chest of the patient, and by lower rib intercostal rib recession. These are all signs of picked up on examination. Wheeze, yes, or crackles. This we have discussed already. On X-ray, yes, the chest X-ray of a typical patient with asthma may be normal, completely normal, but yet sometimes one is looking for is only hyperinflation in general. So hyperinflation on chest X-ray manifests by the long lungs, big lungs, having the cutoff of the anteriorly, if we count the ribs, there is the cutting the mid of the diaphragm more than 6 ribs posteriorly, if you count them. This is showing the sign of hyperinflation. The dark lungs, signs of hyperinflation. Tubular heart, again one of the signs of hyperinflation. Flattened diaphragms, again suggesting the hyperinflation. So these are the few signs you can see the hyperinflation present on X-ray, but you may not get all of these signs and have a typical normal X-ray, which will still be consistent with the diagnosis of asthma. Questionnaires, screening questionnaires, yes, we are discussing. It has to be according to the different practices. The features to decide whether a person has typical asthma or typical COPD, depending on this. So what are those features? We'll just discuss this. If the patient has 3 or more features of either asthma or COPD, then there is a likelihood a person is having either asthma or COPD. Or if you have more than this, few features of this, then this is an overlap syndrome. We'll just show you the slide right now, and we'll clear this slide also. Now this is a slide. So see the features here. Very easy. Age of onset before age 20, COPD after age 40. Pattern of variation over minutes, hours, or day. COPD generally have persistent symptoms. Then diurnal variation, worse during the night. COPD will not have that. They will have good days or bad days, rather than in a single day having all these things together. Generally triggered by exercise, emotions, laughter, dust or exposure, perfumes, more with asthma, not with COPD. So these questions are important because if features are important, if somebody is having 3 or more features of one group, will have the same diagnosis. For example, a person is less than 20, having this variation, Plus there are the airflow limitation, lung features, all these features more than 3 or more are present, then is having asthma. If similarly COPD features 3 or more are present, it is asthma. Okay. But if there are similar features, 3 and 3 features of COPD, both are present equally, you are going towards the overlap syndrome. That's how we diagnose. Coming back to lung function, asthma may have a variable airflow limitation, whereas in COPD, the post-bronchodilator study, the ratio is always less than 70, which shows the persistent airflow limitation, which I have discussed earlier. That airflow limitation persistent means per pre-bronchodilator and post-bronchodilator ratio is less than 70, whereas variable is when the pre-bronchodilator is less than 70, but after the inhaled bronchodilators, after the post-bronchodilator study, the ratio improves to more than 70, which will make it a variable rather than fixed airflow limitation. This is very important. The previous doctor diagnosed of asthma, present already, family history of asthma, eczema, atopy, whereas none of these present here. There will be heavy exposure instead of dust, or this will be of tobacco, biomass, which will suggest COPD. Time course is also important. No worsening of symptoms over time, variation in symptoms either seasonally present from year to year, more in winter season, they all suggest this. Whereas X-ray may be normal, but in COPD generally the X-ray is not normal and showing the signs of COPD or hyperinflation. Step 3, you have to perform this spirometry, and this we have discussed in great detail. In asthma there is, whereas in COPD it is not there. So it's confirming the COPD by doing the spirometry. It has to be done the initial visit as well as in subsequent visits to see the response of therapy as well. Peak expiratory flow meter, yes, but that is not a substitute for spirometry. Please do remember, peak flow meter, we call it very easily. Yes, it is used in the clinic for assessing how much, but it is very effort dependent, and it's a crude test, not a more sophisticated or more reliable than spirometry. It is not more reliable. The spirometry is more better than this. This slide is showing the spirometric differentiation, which I have discussed in detail. The most ratio of improving after the bronchodilators. Okay, and then very important, another part is showing the reversibility. We call it a reversible airflow limitation, or significant reversibility, when the FEV1 increases more than 12%, as well as in absolute amount of 200 ml increase in the FEV1 from the baseline or pre-bronchodilator value to the post-bronchodilator value. But having said that, this reversibility may also be present in COPD at times, so it is not a necessary case. But usually, significant reversibility is a hallmark of asthma, and generally COPD does not have reversibility. And significant reversibility is when two criteria are met: FE1 more than 12% change from the pre-bronchodilator value, and the FE1 increases to more than 200 ml in absolute amounts. Step 4 is start the treatment, and the treatment you start with in asthma, very important. In asthma, you start with the ICS, low ICS. Low dose ICS stands for inhaled corticosteroid. Then you can add LABA or LAMA according to the different steps. We'll just discuss in a minute. Do not give LABA alone. That means LABA without ICS in COPD. The ICS, we do not start with ICS. This is very contradictory. In COPD difference is totally different. You start with the LABA alone, whereas you can't start LABA alone in asthma. The difference is there. And you start with the inhaled corticosteroid in asthma, whereas you reserve the steroid, inhaled corticosteroid, to the later severe form of group D patients in COPD. This is the difference. So if this is what we're showing here in the slide here, do not give ICS alone without LABA or LAMA in the case of COPD. But in asthma, you start with the Yes. Then the overlap, yes, overlap syndrome is treated more the ICS with low dose LABA and LAMA. Step 5 is for referral. Yes, if there is uncertainty or patient is not improving or patient is having exacerbation despite treatment, there are new features, comorbidities present, we are making it difficult to give them inhalers, the person is having heart failure with atrial fibrillation, for example, and giving them bronchodilators increases the risk of putting them into increasing the heart rate, ventricular response to AFib as well. So it has to be considered whether it is a high ventricular AFib with RVR, we call rapid ventricular rate thing. So it has to be taken care of. For these things, you have to refer to specialists or concentrations. Well, the DLCO ABGs, airway hyperresponsiveness, CT scan, they also have a different things, can show the differences between the asthma and the COPD. And I'll not discuss in detail all these things at the moment because I'm going for the asthma control in this. So important goals of treatment are twofold: reduce the symptoms and reduce the risk reduction. So these two, the risk of exacerbation has to be reduced and the symptoms has to be controlled. For this, you need to develop a patient-doc cycle has to be established. Assess, adjust, and review the response. In this fashion, you have to treat the patient. Teach and reinforce inhaler skills. Very, very difficult, and our people are very poor in taking the inhalers, and the correct way of inhaler, they don't take it in a correct fashion most of the time. And you keep counseling them that do not stop the medicines. Once they get the relief after giving the good medicine, the inhaled medicine, they stop the treatment on their own without consulting their physicians, which is a very very alarming thing. And then they come back with the severe symptoms again and saying, "Doctor, again I have to be taken care of." You have to give them advice and reinforce the inhaler skills as well as make them compliant with the medicines, and give them some self-management education as well. Okay, once you are having this, you nebulize yourself one or twice, but do not keep nebulizing. If you are getting more short of breath, you rush to the emergency room. It's better to come to the emergency room in the vicinity of doctors and the required facility, rather than being nebulizing alone at home, again, which can be very, very dangerous. So coming back to the steps of treatment, very easy. Step 1 is for SABA, short-acting beta-2 agonist. Start with this thing. Step 2 is low dose inhaled corticosteroid. Step 3, you add low dose to LABA, bronchodilator. Step 4 is you increase the dose of ICS with LABA, the preferred treatment, or the another way is you add the LAMA, which is the tiotropium. Right, and the last group is for adding the tiotropium or the anti-IgE therapy or anti-interleukin 5 therapy. They are reserved for the step 5. How to assess asthma? 2 domains asthma control has to be assessed over the last 4 weeks. Then assess the risk factors for poor outcomes, including low function. Treatment issues I have discussed earlier as well. That check the inhaler technique and adherence. Ask about the side effects, very important. Does the patient have a written the patient's attitudes and goals for their asthma? Comorbidities like sinusitis, GERD, obesity, sleep apnea, depression, anxiety have to be treated accordingly because they can impair the treatment and control of asthma. How to assess there is a GINA tool, we call it either well controlled, partly controlled, or uncontrolled. So ask these questions whenever the patient comes to you with diagnosis of asthma, to ask in the past 4 weeks symptoms more than twice a week, yes or no? Do you have any nighttime awakening due to asthma, yes or no? Have you used the reliever medicine more than twice a week, yes or no? Or are there any activity limitations due to asthma present, yes or no? So if the answer to these, all of these questions are no, that means the asthma is well controlled. If the answer to these questions are 1 to 2 are positive, 1 or 2 are yes to these questions, then yes, it's partly controlled. If more than 2 out of these 4 questions, so that means the asthma is. The risk factors for poor asthma outcomes is assessed. We have to assess the risk factors at diagnosis and periodically as well, and we ask for patients' risk for exacerbations, airflow limitation, and medical side effects. There are certain risk factors which are for poor asthma outcomes. If you ask in the history if the patient ever intubated and put on ventilator for asthma, this is an independent risk factor for exacerbation. Uncontrolled asthma symptoms despite therapy, having more than one exacerbation in last 12, low FEV1 to start with the treatment, and persisting low FEV1, not improving, another independent risk factor for exacerbation. Incorrect inhaler technique, poor adherence, poor compliance with the medicine, continued smoking with the asthma, elevated FE, fractional extinction of nitric oxide, FeNO in the adults, obesity, pregnancy, blood eosinophilia, they all have independent risk factors for asthma. So asthma severity is assessed, treatment required to control asthma and exacerbations. Asthma severity, if the patient has been on controller treatment for several months, you have to go for it. This is when you assess it. Otherwise, generally it's for mild when it is well controlled on step 1 or 2, moderate if it's well controlled on step 3, which means low dose ICS with LABA, and severe when it is beyond step 3, that is 4 or 5. How often should asthma be reviewed? About 1 to 3 months after the start of the treatment, then every 3 to 12 months. During pregnancy, more rapid, 4 to 6 weeks, and after an exacerbation or hospital admission within 1 week. Stepping is 2 types: sustained setup or short-term setup. Sustained step up, we do it for at least 2 to 3 months if the asthma is poorly controlled. So first we check for common causes of asthma, poor inhaler technique and compliance, then we go for it. Short term, we do it after a viral infection or allergen. This is only for 1 to 2 weeks. We step up, but we step down as soon as after a couple of weeks. Stepping down is very important. We do not step down the good control of asthma unless it is maintained for good. Remember, achieving control is one thing, but it has to be sustained or maintained for next 3 months before we consider to step down the treatment, not before 3 months. Aim is generally we have to go for the lowest possible dose of the controller. This we have discussed when the symptoms have been well controlled and lung function stable for 3 months or more, we consider to step down. And the patient should not have any respiratory infection at that time, patient should not be traveling at that time, and patient should not be pregnant. All these 3 things should be negative, then yes. Primary prevention of asthma, yes, their development and persistence of asthma are driven by gene-environment interactions. For children, there is a window of opportunity exists in utero and in early life, but intervention studies are very limited to show. For intervention strategies include allergen avoidance is very important, but not a single allergen has been effective. So current recommendations about this are: avoid exposure to tobacco smoke in pregnancy and early life. Encourage normal vaginal delivery, advise benefits, and where possible avoid use of acetaminophen or paracetamol and broad spectrum antibiotics the first year of life. This slide is showing comparison of MDIs or DPIs. MDIs are meter dose inhalers and DPIs are dry powder inhaler. Generally, breath actuated or non-breath actuated. MDIs are generally, both types are available, but generally are not breath accentuated. You have to just press it and the things are released in a jet form, whereas DPIs generally are breath actuated and requires a decent inspirative flow or power of 30 to 120 liters per minute. To require such amount of inspirative flow, only 30 is enough, so that makes the difference for either of them. But the beauty of DPI is do not require the coordination and does not require spacer bottle, so it's easy to use. If a person is able to suck in effectively, then it's very good. Coordination is not required, and so in the MDIs coordination is required, but and easily done for those debilitated patients. Thank you very much. Generally, breath actuated or non-breath actuated. MDIs are generally, both types are available, but generally are not breath accentuated. You have to just press it and the things are released in a jet form, whereas DPIs generally are breath actuated and requires a decent inspirative flow or power of 30 to 120 liters per minute. To require such amount of inspirative flow, only 30 is enough, so that makes the difference for either of them. But the beauty of DPI is do not require the coordination and does not require spacer bottle, so it's easy to use. If a person is able to suck in effectively, then it's very good. Coordination is not required, and so in the MDIs coordination is required, but and easily done for those debilitated patients. Thank you very much. Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. I am Dr. Faisal Faiyaz Zuberi, working as Assistant Professor of Pulmonology and in charge of the CHESS Unit 2 at OJA Institute of Chest Diseases, Dow University of Health Sciences, Karachi, Pakistan. Today I am going to discuss a very important aspect belonging to pulmonology, which is known as COPD. As you know, it stands for chronic obstructive pulmonary disease. So let's start. We'll start with the first thing, definition, and apart from this we'll discuss the diagnosis, what is the evidence, how to manage the stable COPD, then we'll discuss about management of exacerbations of COPD, and finally the COPD with comorbidities. So let's start with the basic first thing, the definition. The definition of COPD has been updated recently by the GOLD guidelines of 2017. As you can see in this slide, there is a comparison of definition as given by the last GOLD lines, which were of 2016, and the latest one. The word which has been highlighted shows the difference. So as COPD is a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. Now these highlighted part, the respiratory symptoms, were not included in the previous definition of COPD in the last 4 lines. But now it has become an integral part of the definition of GOLD 2017 for COPD. So the important thing is that they have to be having persistent respiratory symptoms and airflow limitation that is due to airway and or usually caused by significant exposure to noxious particles or gases. Coming over to the another aspect of etiology of COPD and the pathobiology and physiology. About 95% of the cases of COPD are due to smoking. smoking contributes the major burden. The rest almost 5% are due to the environment, pollutants and biomass exposure. So what is the pathophys? Basically it leads to the smoking and other pollutants leads to impaired lung injury, which leads to systemic inflammation. That leads to the classical presentation of small airway disease, emphysema and systemic effects. The systemic effects are basically twofold, mainly the airflow limitation. That is the hallmark of COPD, which is what? Persistent airflow limitation. And the clinical manifestations are dependent on these things. The major symptoms of COPD, how to diagnose COPD, are one, to evaluate the symptoms, looking back to the risk factors, and in the end, finally, as you can see in this slide with the red one, is you have to do spirometry. The symptoms alone or history alone is not enough to make the diagnosis of COPD. One has to do the spirometry. It is a must. So what are the symptoms which may suggest a person might have COPD? Shortness of breath, chronic cough with or without sputum. Those individuals who have a risk factors for tobacco, occupation or indoor or outdoor pollution. Then we do the spirometry and try to get the diagnosis. What is the spirometric hallmark of the diagnosis is dependent on the major values of pre-bronchodilator spirometry as well as post-bronchodilator spirometry. The post-bronchodilator spirometry, to take the ratio of FEV1, which is the forced expiratory volume in the first second, divided by FVC, which is the forced vital capacity. This ratio, FE1 over F20, this is the must criteria for the diagnosis of COPD in the post-bronchodilator study. This slide is just giving you the importance of smoking, which is causing the havoc leading to COPD. Shisha is also very important factor. It's no less than the cigarettes. And even 1 hour of hookah smoking with shisha is equal to about roughly 200 cigarettes. So it's an important entity, often neglected. Biomass exposure, also very important, is showing you the spirometry things which I have just told you. Now, based on the spirometry, the GOLD has divided the severity of COPD or severity of COPD based on only a spirometry, which is GOLD stage 1 equivalent to mild, 2 moderate, 3 severe, 4 very severe. So what is the demarcation point cutoffs for these things? For GOLD stage 1, mild, remember in every stage 2, 3 or 4, the ratio of FEV1, this ratio, FEV1 divided by FVC less than 0.7 is a must criteria in the post-bronchodilator study, not in the pre-bronchodilator. So I am stressing it again and again because it's important. So mild is when the FE1 is 80% or above, moderate is between 50 or 80% of the predicted for FEV1, severe is when the FE1 is less than 30%, and very severe is when the FE1 is less than, the 3%, and very severe is when it is less than 30%. Well, this case is just to show you the spirometry values, how it will help us. Looking at the loop, look at the loop of spirometry here. This is the axis, horizontal axis. This is the y-axis, which is a vertical axis. One graph you can see is below the line, which is an inspiratory loop. Above the line is an expiratory loop. Look at the shape of this expiratory loop, is very excavated, just like a scoop of ice. It's concave up. Can you see this very clearly? It's concave up. This, by looking at the flow volume curve, this is flow and volume, this is highly suggestive of obstructive airway disease. Let's look at the values. As I told you, the must criteria is the ratio of less than 70% in FEV1. So FEV1 over FVC ratio here is, this is the baseline one, is just 26. Pretty? The answer is no. Because I told you it has to be a post-bronchodilator study. So here in the post-bronchodilator is also less than 70, only 28. So the ratio of FEV1 over FVC in the post-bronchodilator study is just 28, which is obviously less than the 70 cutoff. So this means the person is having obstructive airway disease. FEV1, look at the FEV1, it has to be more than 2.34 liters normal range. In the baseline spirometry, it was only 0.93 liters. So it was very, very low. It's 1.01, slightly good, but the change is only 9%. In order to have significant reversibility, the change has to cross the value of 12%. So in this case, it's only 9%, which is less than 12. Secondly, the absolute amount, the absolute value should increase 200 mL or more. So the second criteria for significant reversibility is also not met in this study. As you can see very clearly here, the baseline is showing 0.93 liters and post is 1.0, is hardly after the bronchodilator, and this has to be more than 200 ml in order to have significant plus 12%. So these both criteria has to be met in order to have the significant reversibility. So how we will report as obstructive airway disease without having significant reversibility. And as you can see, is the COPD clinical note already given for review, and he was an ex-smoker, 60 pack here. So all things are consistent with the diagnosis. Now there is a changing role of spirometry in the latest guidelines of 2000. Bronchodilator, as I have already mentioned to you before, is required for the diagnosis. However, in the grading of the COPD, as division, we divide the COPD groups into 4 groups, A, B, C and D. For that thing, in the COPD, the spirometry has been taken off. So now we don't use spirometry in that thing. We'll show it to you. This is the choice of the how to assess the different severity of symptoms. You can use the here, for example, and this can be used to assess the symptom. Now this is the classification which I was discussing with you, that A, B, C, D. This is based on 2 things mainly. One is the severity of the symptoms, okay, which has to be less or more, okay. So A, B, C and D. A is the less severe form, D is the severe form, okay. That's how it goes on. You can see it's written MRC, Modified Medical Research Council score, which is 0 to 1 means less severe, and is the cursor? Yes. Okay. Now here, if a person is having less symptoms, 0 to 1, it is on this column. Either he or she is in A or in C. Then we ask for exacerbation history. This is the exacerbation history, which is what if there is no previous hospital admission in the last 1 year or no exacerbation history, 0 or 1, it goes to this A. If there is, along with less symptoms, 0 to 1, but having more hospital history of exacerbation, it goes to C, which is more. Similarly, if the person is having more symptoms as by MRC, judged by MRC 2 and beyond, more than 2, 2 and more than 2, it will be either in the B category or in the D category. So when it will be in the B category, when there is no prior history of hospital exacerbation. It will be there is history along with more symptom, it is in the last, the most severe form of COPD, which is the D in this group. So this A, B, C, D is important. Now in the latest guideline, the spirometric classification has been taken on. Only these two are used. Previously, as you can see here, it's showing the different, all the grades which I have discussed were also included into it. Now see the implication of this recent change. Take for example, two patients. Here, patient A and patient B are similar. FE1 predicted is less than 30, which means it's severe, very severe category. Here B is also less than 30. Looking at the symptoms which has been included in this guideline, mainly symptom wise is also 18 CAT score, here is also 18. So in the case of symptom also they are similar. But what's the difference? The difference is of the exacerbation in the past 12 months. In patient A there was no history of 1 year. But in the case of patient B, there was a history of 3 exacerbations in last 1 year. So based on the previous 2016 classification, this patient A was classified in the most severe form, that is group D. Okay, but pointer. But in the both groups, in patient A in D, patient B also in D. But in the latest guideline, the patient A was classified as group B, less severe as compared to D. Why? Because there was no history of exacerbation. Whereas the B was kept in the D as per previous classification, because there was history of exacerbation. The role, the impact of taking the exacerbation history is shown in this slide. So what does that mean? That means a removal of FE1 from the risk assessment may result in more patients being classified as less severe stage of gold in previous gold criteria. So more than 50% of patients previously classified as gold D based on airflow limitation alone, that is the spirometry alone, are now classified in less severe form as gold stage B. Alpha-1 antitrypsin deficiency, yes, it is now recommended. It has to be excluded by checking for it, is a recommendation nowadays. Differential diagnosis of COPD obviously is asthma, but asthma can be easily differentiated most of the time. Early in life, often childhood history, then there is variation from day to day, even within the day, also variation or diurnal variation present in asthma, more nocturnal symptom and early morning symptoms with the exaggeration of physiological dipping normally present in the case of asthma. So allergic history of atopy, eczema, rhinitis, allergy, this is more common with asthma. Age is, I've already discussed, childhood COPD is above 40 generally. Then family history of positivity in asthma, whereas COPD will not have that history, and obesity, but this is few just differentiating points. Congestive heart failure, we can easily from X-ray, dilated heart, pulmonary edema, you do the echo and showing the low EF, it will tell you that this is not COPD, this is dealing with heart. Bronchiectasis again is a different, is a large amount of sputum production, and X-ray will showing the cystic changes, and bronchiectasis, tram-line, signet-ring appearance of bronchial wall thickening associated with X-ray or CT scan. Tuberculosis, yes, can be differential, but usually involve the upper lobe rather than the lower lobe, and generally should not have the signs of hyperinflation, as in the case of COPD. Bronchiolitis obliterans or obliterative bronchiolitis or diffuse pneumonia are the very rare disorders to consider. Well, this slide is just showing you the different phenotypical presentations. The classically, the young girl having hand over the chest is most likely having asthma, right? But those elderly male, one is showing very cachectic, lean thing, more pinkish is a pink puffer, and underlying etiology is emphysema at the maximum most commonly. Other one is slightly obese and having blue and obese as well, they represent the chronic bronchitis. The pink puffer and the blue bloater. Another term very important is the overlap. A person is having some features of asthma, some features of COPD, and there is an overlap. We call it ACO, ACO, asthma COPD overlap. Coming over to the next part of the presentation is the evidence supporting prevention and maintenance therapy. Smoking cessation is the greatest capacity to influence the nature of the COPD history. Thing is to stop smoking. Vaccination, yes, it is recommended to reduce the exacerbation and infections. Pneumococcal vaccination recommended for all patients 65 and above. It can be 13, it can be 23, depending on whatever you are using. Pharmacological therapy, showing the beta-2 agonist, anticholinergics, and the combinations of different combinations. We'll discuss this, yeah. So here is the beta agonist can be short-acting, SABA, which include the classical salbutamol. Then LABA, which is most commonly here, Prana's oldest one is salmeterol, then formoterol and indacater. All three are available in Pakistan. The rest are available abroad but not in Pakistan in generally. Anticholinergics again can be short-acting and long-acting. The short-acting one available are the ipratropium bromide. The long-acting available is tiotropium here. The rest is glycopyrronium, aclidium and omalcidium. They are generally present abroad. Methylxanthine is another theophylline phosphodiesterase 4 that is usually for preventing the exacerbation in small subset of patients. We'll discuss this. The most important way to give them is in combinations in one device, combining the salbutamol with ipratropium, combining the formoterol with glycopyrronium, valenterol with omalcidium, different things, different combinations are available. Other pharmacological treatments, if person is having alpha-1 antitrypsin therapy, obviously it has to be given, which is via IV augmentation. Antitussives generally have no conclusive evidence or beneficial role in patients with COPD. Generally do not improve the outcome and on occasion may worsen the oxygen status as well. So the evidence is B according to it. The rehabilitation, education and self-management is the pulmonary rehabilitation. Generally improves the dyspnea and the health status and exercise tolerance in stable evidence. The evidence is A. Education and self-management is also beneficial as evidenced by B and C. End of the care, hospital care, palliative important. And although mortality rates following hospitalization for an acute exacerbation of COPD are declining, but still it is a very important aspect of mortality from 23 to 80% of there. So in the palliative care are the opioids and neuromuscular electrical stimulation, oxygen, fan blowing air onto the face can relieve breathlessness. In malnourished, nutritional supplement may improve the muscle strength or overall health status. Fatigue can be improved by education, rehabilitation and nutritional support. Oxygen therapy is a very important therapy, and the ventilatory support. So during exacerbations of COPD, NIV, which is a non-invasive ventilation in the form of positive pressure ventilation, is a standard of care in certain indications. Oxygen therapy, yes, it also got an important role, but on different specific indications are there. We'll discuss this. So management of stable COPD. The goals of treatment are the same. Number one, to reduce the symptoms. Number two, reduce the risk by relieving the symptoms, improving the exercise tolerance, and improving the health status. And how to reduce the risk is by preventing the disease progression, preventing and treat the exacerbation, and reduce the mortality. So, starting with the treatment modality, Group A patients. Remember, Group A patients which have less symptoms and either no exacerbation or one exacerbation in the last 12 months are in the Group A patients. So, we can start with the bronchodilator and evaluate an effect. Continue, or if the person is not improving, then you can give them regular bronchodilator, the agonist, or short-acting antimuscarinic, either of them. In Group B patients, remember, Group B patients are those with more symptoms but still don't have I beg your pardon, they have symptoms but they have the exacerbations as well. So with that thing, you have to start with LABA or LAMA, the long-acting ones, either of them. Either the beta-2 agonist in the long-acting form or the antimuscarinic in the long-acting one. Either, but if there are persistent symptoms, yes, you can combine both of bronchodilation, which is very much there in the 2017 guidelines. Group C, ICS, the inhaled corticosteroid, is no longer the preferred choice for Group C. So again, you start with the long-acting antimuscarinic agent, and if the persistent symptoms are there, you combine it with the LABA. So dual bronchodilation is again the initial part for Group C, not the steroids. And the last group, you start with LAMA and LABA and look for different things. If there is still having further exacerbation, yes, then you can add the ICS in this subgroup of patients, which is Group D, previously not recommended for Group C and other one. Only in Group D is ICS is recommended in general. And then in a small subset of persons, yes, can consider rofluminast, which is a phosphodiesterase 4 inhibitor, but only when the FA1 is less than 50% of predicted and patient has chronic bronchitis. In another select of patients, small subsets of patients considered, if there are even further exacerbations, even on including the ICS, which is a triple therapy now, ICS, LABA and LAMA. Even then the patient is having symptoms, then you can add either a macrolide or the rofluminast, depending on what I have just told you, the 50% and chronic bronchitis. This is just a summary to show you A, B, and C and D things, and this is we have just discussed. Group A, simple bronchodilator. B, LABA, LAMA, again the same, but you can increase to ICS in the last group. Inhaler technique has to be assessed regularly. It's very important because the poor inhaler technique leads to poor response of the treatment. There is another group of treatment, we call it non-pharmacological treatment, and that includes education and self-management, physical activity, pulmonary rehabilitation, exercise training, self-management, end of life, nutritional support, vaccination, oxygenation. So among this is the non-pharmacological, which is a long-term oxygen therapy. There is a set criteria for this. When there is, you do the ABGs first, it is the arterial blood gas, and when the arterial hypoxemia is less than PaO2, which is the arterial pressure, partial pressure of oxygen less than 55, or the SaO2 less than 88. Or if there is the PO2 is between 55 and 60, but there are signs of right heart failure or erythrocytosis or polycythemia, then you can put them on LTOT and you give them supplement oxygen and ask them what is the target oxygenation is 90% or above. Then you recheck in 2 to 3 months time, 60 to 90 days, and if still the criteria is met, then you have to indicate continue with it, otherwise you can consider stopping it. This slide is just showing you the intervention latest. There are some surgical interventions also via bronchoscope and the open surgery as well for advanced COPD, which includes pulmonectomy and which includes the lung transplant, which includes the endoscopic valve replacement therapy, putting the valve done in a very highly selected patients also and only at few centers in the world. Management of exacerbations. Just before this, you need to define what COPD exacerbation are: the acute worsening of respiratory symptoms that result in additional therapy or change in therapy, classified as mild when they are treated with short-acting bronchodilators only. They are classified as moderate when you go on putting them along with short-acting bronchodilators, adding antibiotics or oral steroids. And the last one is severe, where the patient requires to be admitted in the hospital or visits the ER, the emergency room. Eosinophil level is also an important entity and can predict the exacerbation rates in patients treated with LABA without ICS. So management of exacerbations and those classification of hospitalized patients are classified as no respiratory failure when the respiratory rate is between 20 to 30 per minute. Person is not using accessory muscles of respiration. Person is fully awake, no change in mental status. Hypoxemia is improved via Venturi mass of from 28 to 35, and there is no increase in PSO2, no type 2 respiratory failure. But if another failure but not life-threatening, here the respiratory rate is more, person is using accessory muscle, but still there is no change in the mental status. The hypoxemia is improved with the supplemental oxygen of 25 to 30%, but there is hypercarbia and with 50 to 60 millimeters level of PaCO2. And the last variety of acute respiratory failure, which is life-threatening, all the previous features are present: respiratory rate more than 30, accessory muscle use, but now with acute changes in mental status. And now the hypoxemia not improving, even with eventually hypercarbia is crossed more than 60, or the pH has dropped more than 7.25. All these features make the person with having acute respiratory failure in a life-threatening subset of groups. How to treat the pharmacological therapy is 3 classes have to be given if the person is having management of exacerbation: bronchodilators, steroids and antibiotics. The 3 hallmark should be given to these patients according to the severity. Yes, there are certain indications which I mentioned, especially when there is hypercarbia, type 2 respiratory failure and decrease in pH. And this is known as non-invasive mechanical ventilation, NIV, bilevel, but NIV. But there are indications sometimes, we're mentioning the classical indications for NIV is respiratory acidosis of PaCO2 of more than 45 with arterial pH of 7.35, severe dyspnea with clinical signs suggestive of patients going to fatigue soon with increased work of breathing or both, using the accessory muscles, paradoxical motion of abdomen, retraction of intercostal spaces. Any one of this will make an indications for NIV. And the last one is persistent hypoxemia despite the supplemental oxygen therapy. Indications for invasive mechanical ventilation: when the NIV fails or NIV is not able to be tolerated by the patient, patient is after the cardiac arrest, or patient has a deep comatose condition, very not arousable easily, massive aspiration or persistent vomiting, cannot apply the NIV, you have to intubate them. severe hemodynamically instability, in shock, or having the arrhythmias or ventricular and life-threatening hypoxemia. In all those cases where the person is unable to tolerate NIV, with these features are the indications to stop the NIV or don't apply the NIV, go for invasive mechanical ventilation, that is proper ventilator support. Last, I think slides we coming to the comorbidity is very important. They often exist. Cardiovascular is the major comorbidity, most frequent and most important. Other comorbidities are skeletal muscle dysfunction, metabolic syndrome, osteoporosis. So always one should sort for actively for comorbidities and treat them accordingly, because COPD is a systemic disease, whereas asthma is mainly airway disease. The COPD has a general systemic effects which has to be identified and treated accordingly. Thank you very much. दूसरा भी करना खत्म करना फिनिश करें if you want condition very not arousable easily, massive aspiration or persistent vomiting, cannot apply the NIV, you have to intubate them. Severe hemodynamically instability, in shock, or having the arrhythmias or ventricular and life-threatening hypoxemia. In all those cases where the person is unable to tolerate NIV, with these features are the indications to stop the NIV or don't apply the NIV, go for invasive mechanical ventilation, that is proper ventilator support. Last, I think slides we coming to the comorbidity is very important. They often exist. Cardiovascular is the major comorbidity, most frequent and most important. Other comorbidities are skeletal muscle dysfunction, metabolic syndrome, osteoporosis. So always one should sort for actively for comorbidities and treat them accordingly, because COPD is a systemic disease, whereas asthma is mainly airway disease. The COPD has a general systemic effects which has to be identified and treated accordingly. Thank you very much.